All right, we're going to go ahead and get started. Good morning. Here in Texas, it is the morning. So a very happy day to you wherever you are in the world. My name is Chris Moreland. I am the presenter today. Happy to partner with the NDC team. First, I really want to thank NDC for inviting me to present here. What an amazing conference and such rich discussions. I really appreciate it. My talk today is going to focus on pathways to and through health science education for deaf professionals. First, I'd like to briefly introduce myself, then we'll do a little access check. I am an internal medicine physician. I work in Austin, Texas at Dell Medical School at the University of Texas, Austin. I'm faculty here. I'm a professor on the faculty involved with medical education, and I have done that work for over 10 years. I have strong interests in supporting deaf and hard of hearing folks through health science professions educations as they navigate their professional journey and identify barriers moving through that process. Access for this event is the chat, which the NDC team will post information. We have captioning available, interpreting access available. I am signing today. I have two interpreters here who will also be on screen, and will be translating my sign into spoken English. Next slide, please. This picture is from the year 2000. I put this picture here not because I am in the photo, but for me, this represents the beginning of a huge movement. There are several healthcare professionals who are either students or future professionals in this picture. And I had not yet started med school at this time. I was just about to start med school. The picture also includes two other medical students, a dental student, and a veterinarian. This was in Boston. Several of us had gotten together to just talk about things, about health sciences education, what the future could look like, what that experience was for us. At that time, we didn't have much data. Really, there was no data to help us understand what the path through health science education looked like for deaf and hard of hearing people. Next slide, please. Since that time, in the past over 20 years now, especially in the last 5 to 7 years, we've compiled so much more data. Those data look specifically at the experiences of people with disabilities in health sciences education. Of note, many people, including myself, who are deaf or hard of hearing, may not specifically identify as having a disability. Deaf and hard of hearing people don't always identify as having a disability. This research looks at disability as a whole. However, we also talk about a lot of information within this regarding deaf and hard of hearing communities in health sciences education. The goal is not to review or provide a systematic review of the comprehensive data here. My goal is to give your team and your institution and you as a deaf and hard of hearing person information that may help you plan strategically for access to health sciences education or to develop your career from the place that you stand now. The data you see here on screen represents the best data we've gotten thus far. It describes the number of people in med school or physicians who identify as having a disability. About 3% of physicians who have completed training identify as having a disability. Looking at residents, about 7.5% of that group identify as having a disability. And in the group of students, over 9% identify as having a disability. Next slide, please. So this is a little bit more granular information about deaf and hard of hearing people within the group that I just mentioned. Around 2% of those who identify as having a disability are deaf or hard of hearing. Next slide, please. Having a healthcare workforce that includes deaf and hard of hearing people, we might want to look at what rationale is there. My rationale thus far has several different components, which are listed here. People think about deaf healthcare professionals, doctors, veterinarians, nurses, and so forth. With the deaf and hard of hearing community, when they are able to communicate directly, that improves communication access. It also exhibits concordance, patient-clinician concordance within that therapeutic environment. We do have some data looking at deaf patients with signing physicians compared with deaf patients who do not have signing physicians. In the group of deaf patients with signing physicians, they are more likely to get recommended healthcare interventions such as flu shots, cancer screenings, and so forth. Another rationale relates to career goals. Some research that my team did several years ago looks at deaf and hard of hearing students, physicians, and healthcare professionals. Within that group, often, deaf healthcare professional students estimate their future patient population will be about 1/3 deaf or hard of hearing patients. Deaf healthcare professionals who currently were working at the time we did this study, about 1/3 of their patients at that time were deaf and hard of hearing. In other research, looking at medical students who had physical or sensory disabilities, more often they were interested in pursuing primary care fields. And that is an area that we have a desperate need for here in the United States. So it seems that deaf and hard of hearing people are interested in working with underserved communities, on average, more than the typical physician or healthcare professional. Now, I do not say this to mean that deaf healthcare professionals are expected to work with those patient populations. The data just suggests that the interest is there. Next slide, please. A couple of brief stories of mine. During my training, I worked with a deaf patient as part of my primary care clinic. One patient who was deaf had diabetes. We sat down and discussed the need to start a new medication, and we both recognized that her primary language was ASL. She preferred ASL and much preferred ASL over English. So we discussed how she would take that medication, and I moved to the computer to type up the prescription. At that time, I realized that I needed how I typed the prescription to match what our discussion was in sign language in a way that this patient could understand it. So I typed up the prescription, asked the patient to read what I'd written, and she and I negotiated the language that the prescription had that would reflect our discussion. That conversation may not have happened if I didn't have the experience and recognize the language preference and how that communication and her communication style would influence her taking her prescription. Next slide, please. This is another part of the rationale for including deaf and hard of hearing people in healthcare, and that's contact theory. Deaf physicians or healthcare professionals with patients who are deaf, again, exhibit concordance. And that's not the only way that having deaf healthcare professionals improves the workforce. When there are deaf and hard of hearing healthcare professionals working with other healthcare professionals, interacting with them, and they are not deaf, and they are able to see and learn and communicate and develop approaches and strategies for working with deaf and hard of hearing colleagues. They are able to use those strategies when working with their own deaf and hard of hearing patients. And that approach, the way that the diversity in the healthcare workforce bleeds over to other healthcare professionals and then to patients, is one way that we see how contact theory benefits. And this is another rationale that can help you in your discussions with your programs and institutions. Next slide, please. Pathways through healthcare professions education. I'm going to go ahead and quickly touch on these, not fully go into them in any depth. We're just looking at the bigger picture here. These are the typical pathways. We have pre-professional education. This could be college, community college, universities, etc. Then students move to professional health science education, med school, nursing school, pharmacy school, etc. After that, there are some specialties that will have advanced training, which is usually called residency or residency programs, and those are required for physicians, some pharmacists, and some nurses will pursue that additional training as well, especially for those who are doing subspecialty training. And then we move into clinical practice. And at that point, education does not stop. There's still continuing education that must be maintained. Next slide, please. We're going to focus our next comments on professional education. Maybe you noticed my data so far have strongly focused on physicians and med students. You may be wondering why we're not talking about other health sciences professions. Understand, almost all of our data right now is from physicians, and we are hoping that will change. So, looking at med school, if someone is deaf or hard of hearing and thinking about applying to medical school, how do we identify which programs might be a best fit, both from the perspectives of culture, theoretical educational approaches, etc.? All medical schools in the United States have a document called the Technical Standards document. Those technical standards describe the skills, competencies, and such that are expected for students to work effectively and be able to succeed in med school. Things such as communicating well with patients and colleagues, assessing and pulling in information from the history and physical exam. Our team looked at all med schools' technical standards and identified that many were very hard to find. They were difficult to find on the website, difficult to get by contacting the school directly. If we can't access those standards, then we can't see their policies and requirements. 1/3 had language that seemed supportive of disability experiences. For example, we welcome applicants with disabilities, or we will provide reasonable accommodations and support diversity, etc. Half of those had no clear policy and about disclosing disability or requesting accommodations. And another study we did in 2022 found that things had essentially not changed in that time. So deaf and hard of hearing people already have challenges figuring out if programs are going to be welcoming or not. Next slide, please.
So I'd like to talk about the data that we have in terms of access. Medical students with disabilities have been identified. Well, let me back up. So medical students with disabilities versus medical students without disabilities, when we look at these two populations, when we look at students with disabilities, they are further subdivided. Medical students with disabilities who have disclosed to their program or institution and are satisfied with the accommodations that we received, or students who have disclosed but have indicated that they do not need accommodations or don't receive accommodations or might be too afraid to ask for accommodations. So when we look at those three buckets, students without disabilities, students with disabilities who have their access needs met, and students who have disabilities whose access needs are not met. It seems that we've identified some risks for burnout within those buckets, within those groups. And it increases as we move across those groups. Students with disabilities who do not have their accommodations met are at higher risk for burnout. For people with disabilities, having access and having their access needs met satisfactorily, that is a risk reduction for burnout within those students. So we see a decreasing step off the more people have their needs met. It doesn't entirely resolve the differences between students with disabilities and students without, but it does decrease the risk. We see that same pattern in terms of burnout risk for a possible symptom of depression. Next slide, please. So keeping in mind time, this graph indicates what I just talked about. So move on to the next slide, please. In brief, this graph shows that we asked deaf and hard of hearing medical students and physicians what accommodations they use and when, at which stage of their training, during school, residency, or within practice. The point of this is not to get too specific, but just to look at the numbers across the stages of training and where accommodations are most frequently used. People use a variety of accommodations and use their accommodations at different times in their career. So I think it's important that we realize to support deaf and hard of hearing people that are looking at entering health sciences education, we need to recognize in advance that they might need different accommodations at different stages. That information is also helpful for institutions and programs in schools. Next slide. We asked those people in the survey who were deaf and hard of hearing students and physicians how much time that they felt they spent on average each week managing or arranging their accommodations and services. The responses on average were about 2 hours a week, and that is not insignificant. So if you imagine your own work schedule during the week and you have to add an additional 2 hours of work, that can have an impact. On average, the range, that was the average. But when we look at the range, some people felt that they didn't spend any time or insignificant time, maybe because they didn't use or didn't need accommodations. The maximum in that study was indicated at 10 hours each week, which is, more than a single workday. It's important that we understand deaf and hard of hearing students and professionals' workloads, not just the professional time workload, but also how much time they need to spend over and on top of that to arrange their accommodations. And we need to make sure that we are supporting them in those efforts. Next slide. So we just talked about medical students. Now I'd like to move and look at residents and residency programs. Next slide. So as I just indicated, with the pattern of access needs and how that reduced the risk of burnout and depressive symptoms, again, when we look at residents, these findings are even more strong. If we look at residents with disabilities who have access, they don't have any change in their depressive symptoms compared to their non-disabled colleagues and peers. Now, when we look at residents with disabilities whose access needs are not met, we see an increase in the risk of depressive symptoms in comparison to those without disabilities. So when we look more granularly at this, we can identify a group of residents who didn't request accommodations, but have needs. And they were asked why they didn't identify. And there were three common reasons that arose. One was concern of stigma and bias. Second was there was a lack of a clear process for requesting accommodations, or there was a lack of documentation of disability access needs. So these are three opportunities for us to plan ahead and anticipate what deaf and hard of hearing students, trainees, and professionals may need as they matriculate professionally. Next slide, please. So we've talked about schools and education. We've talked about advanced training, such as residency. Now let's look at what happens after training has been completed, and we don't have much evidence currently. Next slide. One study with the AAMC, which is the Association of American Medical Colleges, that's an organization that oversees medical schools. They conducted a national survey, representative survey of physicians across the United States, those who have finished their training. Of those who reported having a disability, 64% of practicing physicians reported experiencing mistreatment within the last 12 months. The mistreatment came from both colleagues and patients. Next slide. I'm going to move quickly through this, but the point of this is essentially the mistreatment took a variety of forms. Sexist commentary, other offensive comments or remarks, threats of physical harm or violence, or actual physical harm or violence, unwanted sexual advances. Those, again, are from both colleagues and patients. I'm going to skip the further information on this slide and move on, please. Next slide. Thank you. My comments thus far have seemed to be overly negative, but many people who respond to the surveys indicate a positive response. They like their work, they have access, they're satisfied with the accommodations that they have. Overall, their responses are positive. So how can we optimize the experiences of deaf students who are looking at health science education so that all of their experiences are positive and are encouraging for them to further pursue their career goals? First, we need to empower them with information. I've had a number of conversations with deaf students over the years talking about med schools and their technical standards, what that means, how to identify those documents, what to look for when you read them. So, for example, we found two kinds of language in the technical standards documents. Some more focused on how people do things. So, for example, oral communication with patients versus objective. You must communicate effectively with patients, but it doesn't prescribe how that happens. Next, helping people explore a variety of career pathways, what the variety of options are within the healthcare field. Healthcare is wide-ranging. It's not limited to just physicians or nurses. Also, identifying the role of disability access resource professionals, many of you who are in the audience today. Sorry, my computer's trying to restart, so I needed to delay that. We need to help people learn how to document what their needs are as early as possible. Medical schools have 3 standardized exams called the steps. There is step 1, step 2, and step 3. We have recognized for a number of years that medical students who have identified themselves as having a disability and needing accommodations, but have no history of accommodations, have a more difficult time receiving accommodations on the step exams. Next slide, please. So this, in terms of leadership and communication skills, why do I have this here? I feel very strongly about this. I believe that we as deaf and hard of hearing people, through our experiences navigating life, we become expert communicators. We know how to accommodate to different people and their communication preferences. Deaf students often are masterful in coming up with very creative ways how to navigate interesting challenges or circumstances when they're trying to communicate with somebody. Because access often is not there, so they are left to create it. Which means that we as deaf people have to identify what our own access needs are and know how to express those needs to other people. Maybe when we communicate those needs, that conversation might not go well, or we might meet some resistance or even confusion, and then that becomes a different kind of challenge. All of those skills are crucial in a leader. And I believe we need to encourage and foster deaf and hard of hearing healthcare professional students and professionals who are already working to identify and overtly name those skills. Next slide, please. This ties in between leadership and self-advocacy. When we look at the connection, and as we've seen over the years, people with disabilities, people who are deaf and hard of hearing, struggle with advocating for ourselves for a variety of reasons. It could be that they're not trained, they have no experience, no formal education on how to do that. They've had to learn the hard way how to develop those skills. The time investment and the energy investment that takes is incredible. We can support deaf students and prepare them for their careers by identifying how to develop strategies for themselves. So, for example, what resources are available? How do we disclose our deafness? When should we disclose our deafness? In an application or wait until the interview? How should I disclose, and what does that language look like? How do I share that information in a direct and professional manner? Students who have experienced stigma, autism, ableism, need to know how to manage those experiences and how to bring those forward to the leadership of their institutions in order to solicit and receive support. But to be clear, I don't mean that we need to put all of the onus on the student. That is not my intention. Institutions have a great deal of work to do in changing their policies, improving their technical standards, to facilitate those changes to support deaf and hard of hearing students. While we work on that, we also need to support deaf students in navigating the system. Something that I have often found helpful in talking to deaf students about what their interests are in the health professions. The conversation sometimes can be too abstract. It helps to make that conversation more concrete. So visiting a hospital or a clinic, looking what the inside of an operating room looks like, actually seeing the physical environments helps people have a better understanding of what they might need when they interface with those specific environments. So I would encourage all of you to look for and take advantage of opportunities to work with students and visit environments where they're interested in studying, working, and practicing. Again, I'm aware of my time, and I know that the NDC is also looking at my time. So I'm going to start to wrap up soon to allow for some question and answer time, but I do have a couple more comments I'd like to make.
A key point here is mentorship. It is absolutely crucial and key for everyone's success, especially deaf and hard of hearing students. I encourage you all to find ways for deaf students to connect with mentors. How do we do that? Let's go ahead and go to the next slide. Full disclosure, I am on the board for the first organization listed here, Association of Medical Professionals with Hearing Losses. We are deaf and hard of hearing healthcare professions across a number of healthcare fields: doctors, nurses, veterinarians, pharmacists, etc. I am not paid for that work, but I am involved. And the organization has been around for more than 20 years at this point, has provided mentorship, networking, and advocacy for deaf and hard of hearing healthcare professional students. Those conversations help people at institutions where the institution might have 1, 2, or no other deaf or hard of hearing people. And it's hard to find mentorship with that same experience and understanding. So I encourage people to look outside of their institutions for mentorship that can be part of their mentorship committee, so to speak, or of their mentorship network. Next slide, please. A few other resources available. On the previous slide, you saw the Docs with Disabilities Initiative. That organization is doing a lot of work in the healthcare profession space related to advocacy. The AAMC, again, related to medical schools, has an online disability inclusion community that is available for questions, comments, sharing of ideas, etc. Next slide, please. I've been in discussions we've been discussing doctors, medical students, etc., but looking at other professionals, pharmacy education, as you see here. This was a recent webinar that was hosted. Next slide, please. Another example of a webinar focused on nursing education with the Macy Foundation. Next slide, please. And of course, NDC, an invaluable resource. If you haven't taken the time to read through NDC's website, there is so much information there that is related to other organizations as well. And our team here has developed a lot of resources specifically for students interested in health sciences education. Next slide, please. So the picture that I started with from the year 2000, we had just a few folks there. In 2018, this represents 2 different boards of AMPHL, the Association of Medical Professionals with Hearing Loss. One team was outgoing and another team was incoming. That picture represents deaf and hard of hearing surgeons, primary care physicians, researchers, pharmacists, pediatricians, psychologists, and a variety of healthcare fields. I haven't even named everything yet. So we've come a very long way, but we still have a lot of work to do. Next slide, please. Thank you so much. Here's my contact information. I'm happy to continue the discussion and answer questions now.